Alright, so today we were supposed to move on to talking about dyslipidemias and the rest of this cardiovascular topic basically, which are not that intense, but there are certain things here that are going to be a little different and out of whack compared to what you might have seen in step 1. So the dyslipidemias are mainly just mentioned here as high cholesterol levels. Right now in questions, be very careful. They'll often just tell you the total cholesterol level, which is usually going to be a problem if it is more than 200, but remember with this, they don't really break down for you how much of that is LDL and how much of that is HDL. There's usually been a tricky question going around where a person works out and does a lot of things to lose some weight and get healthier, and then they ask you which one of these things would not decrease. And the thing that would not change basically is the HDL level. This is never really going to change that easily just from exercise and stuff. Exercise and stuff may cause more LDL reuptake and lower your cholesterol in general, but HDL doesn't really tend to change that much, right? Even your triglycerides would decrease when you work out a lot, right? But not your HDL level. So back in step 1, you had your dyslipidemia actually discussed over here. They're not taught again in the CK book. And here at the bottom, you can see, you can pause it in the recording, that there are some easy ways of memorizing these guys, right? So I have these things I made up back when I was studying and back when I was also reteaching these things on my YouTube channel that help you kind of memorize what the differences here are between all of them. So you have your type 1, which is chylomicronemia, right? So you see the word 1 in here. This one, hyperchylomicronemia, is too much chylomicrons. That's all it really is. It's in the name. Too much chylomicrons because you don't have lipoprotein lipase function, or you're missing its cofactor 2. Apolipoprotein C2 deficiency, right? So these guys kind of work together. If either one of these things are not there, you're not going to be able to reuptake all these chylomicrons. So if you've forgotten all of that, that's something you look up over here, right? What each one does, right? So C2 is just a cofactor. I also like to think of this as CLL, the LL for lipoprotein lipase, right? So that's something that it reuptakes basically your chylomicrons. You don't really care about these parts right now, but just chylomicrons, that's all it does. So it's nice that it starts with a C. The C should remind you of chylomicron as well. And in these people who don't have that, lipoprotein lipase or C2, they have too many chylomicrons floating around. So all those chylomicrons then eventually, since they're just full of lipids and stuff, end up causing pancreatitis. Right, and one of the key things that are often not given away in a question is that when you take their blood and you spin it, you get a creamy layer in the supernatant. Right, so that's one thing about these guys. Type 4 is the other guy that also has pancreatitis. Once again, because too much triglyceride, right? So chylomicrons and triglycerides. Chylomicrons are kind of full of triglycerides. That's one of the key things there. Let me see where we can see that. So when you come back up here, you see it, right? The main chylomicron that comes is just full of triglyceride. That triglyceride never really goes anywhere. You either store it away or you put it in the body, or you actually end up using it for energy as free fatty acids here, right, in adipocytes. But generally speaking, that's all a chylomicron is. It's a bubble full of triglycerides. So here you once again have triglycerides in the type 4, right, which is 4 letters for VLDL. Right, so VLDL and triglycerides are going to be super high in these people, and they end up often being pretty obese, which, you know, all the excess triglycerides leads to insulin resistance, and then they often also have the darkening of skin in the axillae and behind the neck. Okay, so these are some the acanthosis nigricans thing. These are some things you look for. So type 1 is also more recessive, and type 4 is also more dominant. Okay. So that's the even numbers are constantly dominant. 2 and 4 are both dominant. All right. So 1 and 4 are very similar to each other because they both cause pancreatitis due to the excess triglycerides. 2 and 3 are similar to each other because they both lead to more atherosclerosis, which is one of the topics we're going to talk about today. Type 2 is familial hypercholesterolemia, which basically has defective LDL receptors. So you're unable to reuptake your LDL from circulation, which means that all the LDL just ends up staying in the circulation. And that's not good because that's exactly how you get atherosclerosis. Now, heterozygotes have a smaller amount. The homozygotes who have basically full mutation. Remember, autosomal dominant means that you can have just one allele or 2 alleles. Either way, you're going to get the disease. If you have 2 alleles, then the disease is far worse, and their cholesterol level is going to be way over 700. So we just saw that usually the pathological number is more than 200, But for these guys, it's crazy, right? More than 300, more than 700. And all of this LDL leads to accelerated atherosclerosis, causing an MI before age 20. This often tends to present in questions in a very tricky manner, where you get a patient who died while playing sports or something, and they make you think of the hypertrophic obstructive cardiomyopathy, right? But that's not what this would be. And the only way you'll really cast the difference is if they mention anything about cholesterol levels, or they tell you that the patient has an Achilles xanthoma. So I like to think of this as the Achilles xanthoma guy, right? For type 2, the familial hypercholesterolemia is the only place. This is apparently, as far as tests are concerned, this is apparently very specific to type 2 hypercholesterolemia. Right? You only see the Achilles xanthoma in here, where people don't have the LDL receptor, so they can't take back the LDL they release. Dys-beta lipoproteinemia and A-beta lipoproteinemia, these are two different guys that are also problems. The dys-beta is type 3, so 3 for ApoE, right? Or you can think of it as dys-beta lipoproteinemia, right? 3 for ApoE, you're unable to have ApoE function. ApoE, E is for everything. It takes up everything. So now you have the chylomicrons from here, as well as the VLDLs from here. It's a combination disease. And all that VLDL, as well as all the chylomicrons, they just basically end up causing you to have weird things all over your body. Right? It seems like it's the most simple one to have, though. If you have to pick between, which one of these four you would want to take onto yourself, if you had to have one of these diseases, it would be type 3, because you just get a lot of premature atherosclerosis and palmar and tuberous xanthomas, but these guys don't tend to have so much atherosclerosis that they end up dying. And it's pretty treatable. As you could tell, for most of these guys, you're going to need to give them all statins and fibrates, or statins or fibrates, depending on what the key thing is, right? So, for example, type 2 and 3 would both need statins, because the main issue is the LDL and cholesterol. Type 1 and 4 would both need fibrates, because the main issue is triglycerides, okay? So, that being said, those are all your main dyslipidemias, and patients will present with symptoms based off of how bad the lipid layers and whatnot are, right? So you got your xanthelasma, right? You get all the xanthomas and stuff, and the Achilles xanthoma and the type 2 guy, like we said, that's basically it. So how do you diagnose somebody who pops up with symptoms of these things? Well, the first thing you do is you order a fasting lipid profile to see how their cholesterol and LDL and all that is, right? You conduct a fasting lipid profile for patients over 35, or in those with over age 20 and having a risk factor for coronary artery disease, such as maybe somebody who's diabetic and hypertensive at a young age because they're also obese. Right? And repeat every 5 years. So now here you're starting to see things are getting a little more technical, right? Especially in the second bullet. Right? So this is going to be a type of question where you're going to get some patient that comes in for routine evaluation, and then the question is going to ask you, what test should you order for this patient, Amir? And that's when you pick something, right? So let me see. Listen to this voice message real quick.
Hey, I just left, so I'll be there soon.
All right, perfect. LDL. So for this patient, when a normal person coming in for routine exam and whatnot, depending on their age or comorbidities, it should be pretty commonsensical by this point to know to order a fasting lipid profile. Pretty much all of us get this done when we go in for our regular visits anyway. So you would definitely do it, and then you would order it every 5 years or sooner, depending on how the first one came out, right? So if you ordered a fasting lipid profile and everything's perfectly fine, and the patient's doing okay, you don't need to order it again, right? It's not really going to be necessary. Theoretically speaking, though, in real practice, we do keep ordering it because it's not that hard to, and it's not like it takes a separate blood draw or anything crazy like that. But for exam purposes, if the first time you ordered it, it was perfectly fine and the patient doesn't have symptoms related to cholesterol, HDL, or any of these things, don't order it again for the next 5 years, okay? But after age 35, right, you basically order it once for sure, just to make sure everything's okay, and then depending on how bad it is, you might have to order it again, right? So you always need to reorder these things if you gave medication to treat it, because then you need to see if the medication is working. That's the basics of breakdown over here. So you just spend some time checking all this out, making sure you know how all this works. Always pay attention to the key facts over here. These are very useful things they mention. Very good key facts. Each key fact is basically another possible question you can get. A possible question you can get, or a possible presentation you can get. For example, when we get to endocrine, we're going to see that secondary hyperlipidemia causes include Cushing syndrome, hypothyroidism, nephrotic syndrome, or cholestasis. All of these can cause hyperlipidemia. Right? So you need to know all the different kinds of things that can occur that can cause hyperlipidemia. And then here you have a thing for the American College of Cardiology and American Heart Association treatment guidelines regarding atherosclerosis. Right, so it's all topics relevant to the dyslipidemia. We finished all of this already. So now here what you're seeing is what test you're supposed to order and how you're supposed to treat it. Okay, so generally speaking, for all of these, you're going to order the same test, which is your fasting lipid, right? And depending on the age, treatment would only slightly vary. Okay, generally speaking, if you have a person who's over age 21 and their LDL is very high, you go ahead and put them on a high intensity statin. Now this is where things get a little weird. Not all statins are the same. They're not all the same. Okay, so very important to remember that. Rosuvastatin is a lot stronger than atorvastatin, and so on. So you might get weird questions where you get, a topic about which statin is better than the other. So let me actually check something really quickly if I can find it right now. Statin intensity, and then I'll put that here for you guys too. Statin intensity. Yeah, so here we go. This is a nice image. They put it in the book for you guys right now so we can see it. So if you just Google this, you can see, right, these are your high intensity statins, rosuvastatin and atorva. Okay, moderate intensity, and then low intensity is Simva. So I think I just earlier in the video said Rosuva and atorva, that Rosuva is stronger. I meant that they're both the strongest. These guys I always remember together. Okay, Rosuva and atorva. Simva you think of as simple, is the low intensity statin. So why would you want to use low intensity statin in someone? Because you might give somebody a high intensity statin because they really needed it, right? They have bad cholesterol, but then they might get the side effects of the muscle pain, right? So if that happens, you can't take them off the statin because they still need it. So you put them on the lower intensity statin, and that's what's happening here. All right, but all the statins have different intensities. Obviously, they're the same class of medications, right? They're all statins, but they have different intensities. So this is relevant to things you would do in pharmacology regarding potency and half-life and stuff like that. So these guys are definitely much more potent and much more effective too. So that's kind of what they're talking about with high-intensity statin. Other than that, though, I hope you won't get weird questions where you have to pick between a high or moderate intensity statin. That would become a very difficult question. Right? So, for example, if you look at this group here, 40 to 75, LDL of 70 to 189, if there's a more than 7.5% 10-year risk of having a coronary artery disease kind of heart attack issue, you put them on a high intensity statin. And if the risk is not that high, less than 7.5%, then you put them on a moderate intensity statin. So, that being said, the lesson to take away here is that if you know your patient is at a high risk of having cardiovascular disease, getting cardiovascular problems, and possibly getting an MI, you put them on a high intensity statin. All right. If the risk is very, very, very low, you don't even do anything about it. Okay, so it all depends on where the LDL level is standing at. Right, an LDL of 70 is okay, but an LDL of 180, not okay. And over 190, anyone over 190 LDL, you always put them on high intensity statin, no matter what age they are. As long as they're age over 21, you put them on a high intensity statin if it's over 190 LDL. Not the total cholesterol, but the LDL. Most questions often tend to try to trick you by giving you the total cholesterol. So it all just depends on those things, right? Whether or not they have a risk of getting heart attack, whether or not their LDL level is very high or low, if they're obese, what other comorbidities they have, what family history they have of coronary artery disease, and so on and so on. Right? All these medications are things from, once again, step 1. So if you forgot any of this, this is only a very basic revision here. So you want to make sure you go back to first aid step 1 pharmacology, look them over again, make sure you have a good understanding of these medications. Then they move on to the topic of hypertension. So we'll come back to this table. Hypertension starts right here. Now, hypertension can be primary, essential, or secondary to some other issue. Most case scenarios are going to be about primary, essential hypertension in the real world. But on your step 1 and step 2 CK, you already saw in your step 1 and you're going to see in your step 2 that most causes of hypertension in step in general are secondary causes, because that's more testable stuff. Essential stuff is not that testable. Essential hypertension is someone that just has hypertension and you can't really do anything about it, and that's all it really is. So let's let me show you guys something here real quick. So yeah, here we go. Right, in step 1, it wasn't that big of a topic of discussion. right? Everyone knows what hypertension is. They had this discrepancy between urgency and emergency, right? Where emergency is obviously the worst case scenario, where they end up having end organ damage, right? So these people can go blind or have kidney damage and possibly even die from a stroke, right? So that's where it gets really bad. Encephalopathy is a pretty far extreme presentation for hypertension, but yeah, generally speaking, it's just going to be the stroke and retinal hemorrhage and stuff. Now, secondary causes they barely talk about here, right? But they do tell you it's either going to be renal vascular disease or fibromuscular dysplasia. That's all they really mentioned here. Now, step 1 in NVME always loved renal artery stenosis as a topic of hypertension. It's such an interesting topic because you can give these people who have renal artery stenosis, if you give them an ACE inhibitor, which is the typical medication of treatment of hypertension, you end up noticing that it actually worsens their hypertension. And for fibromuscular dysplasia, you have this NVME question here, and this image, as well as the image in the book, which is just showing you the stringing of beads, right? The beading that's happening. So it's not such a intensely difficult topic. But in CK, it's more difficult because now you see the complete breakdown of things. These are all the common scenarios that occur in everyday real life where something led to secondary hypertension. So hypertension, they have this table up here now. So you see normal elevated stage 1 and stage 2. So stage 1 is like early stage hypertension, right? So you have this 130 to 140 thing happening here, right? Elevated is 120 to 130, which is basically, or 129 is what they write, which is basically, in a sense, pre-hypertension, right? So you don't really need to start medication here. You just tell them to, stop eating so much salt, maybe work out a little more, and that's it. And if things keep getting worse, then it can break 130, and now their blood pressure might be between 130 to 139. So then you have to assess their 10-year risk for heart disease and stroke once again, which is the same table we were looking at up here. Right? You look at their risk for having heart disease and stroke, same thing for treatment of dyslipidemia and hypertension. So if their risk of having stroke was high, you had to give them the statin. And if the risk of having stroke is high here as well, you have to maybe start them on medications. Right? So here, look at how many times they reassess before they finally start medications. That's a very important thing. You're going to get questions where a patient came in with a certain amount of hypertension, and then there's going to be answer choice. It'll ask you what's the next best step. Usually, the next best step, if you just identified this hypertension, the next best step is to just go ahead and retest them. Right, reevaluate, reassess that hypertension. So that's something that you look forward to doing. Be very careful in picking those answers, right? You don't just order medications right away. Sometimes people have high blood pressure because of common things you've probably heard of, like white coat syndrome, general stress, maybe they were in pain, etc. Right? So it's not actually hypertension, it's just momentary. But if someone has hypertension in multiple, and I think in the book it says, 3 visits. So let's take a look. You get a patient comes in with hypertension. Okay, how do you deal with it? So quantifying overall risk, you obviously have to see if they're diabetic, which is something that can cause hypertension, and if they have bad lipids, which can also cause hypertension, and then exclude any secondary causes, which we're going to look at pretty soon. Begin with lifestyle modifications. After the first time you see blood pressure starting to go above 120 and it's still under 130, you tell them to do some of these things and change their lifestyle. It doesn't work, things get worse, then they come back and it's still high. So now blood pressure goals vary by category depending on the table we were looking at, right, with the high level statins and stuff. Diuretics, calcium channel blockers, ACE inhibitors, beta blockers, all of these are great medications that are actually shown to reduce mortality. And this is the list I was talking to you guys about in the last time we were talking about. I think in the last video I mentioned that there was a group of medications that actually lower mortality. And then there are other medications that, they just help, but they don't lower mortality. So you get questions where they ask you, which one of these medications would you give to reduce mortality? And you get all these answer choices that are actually medications you would give for hypertension, but only one of them is going to be from these classes, and these are the guys that reduce mortality. These are great medications. Whereas the treatment of hypertension ABCD, they're basically all guys that, everything here are all guys that reduce mortality. Right? Calcium channel blockers, diuretics to lower the fluid loss, also help you lose salt. ACE inhibitors to keep your kidney is nephroprotective. Beta blockers also great, helpful for your heart too. Right? These are all great, and they reduce mortality in uncomplicated hypertension, which basically means hypertension that isn't complicated by other secondary causes or other problems. They are first-line agents unless a comorbid condition requires another medication, like maybe they have heart failure or really bad diabetes or something. Right? ACE inhibitors are the perfect thing to give in hypertension and diabetes. So this pharmacology stuff is actually broken down very well in first aid step 1. Right, where look, they actually did the breakdown. Who do you give what to? Hypertension with heart failure, hypertension with diabetes, hypertension and asthma, where you wouldn't really want to give a beta blocker unless it's a cardioselective beta blocker because your lungs have beta 2 receptors, right? And then hypertension in pregnancy, where we notoriously use labetalol. So very important breakdown over here in first aid step 1. Use both books side by side. Very effective thing. Now, how do you actually, go ahead and deal with these people? You keep giving them new medications, and you keep adding more medications until things get better. So, for example, for patients over age 18 with chronic kidney disease, ACE inhibitors and ARBs are nephroprotective. We already know that. We know African American patients. This is something that Step 1 and NVME loved talking about back in the day. That people who are African American, the number one treatment for their blood pressure is actually not ACE inhibitors. They're more so affected by thiazide diuretics. Thiazide diuretics just happen to work a lot better for them. And CCBs, but the thiazide was the main thing. If blood pressure goal is not reached within 1 month of commencing treatment, increase the dose of the initial drug or add a second drug. And if goal blood pressure cannot be reached with 2 drugs, add and titrate a 3rd drug as well. And you'll see a lot of people who have 3 drugs for their blood pressure. They might have lisinopril, amlodipine, and some other 3rd drug, like a beta blocker, maybe metoprolol, also mainly because they also have diabetes or something, right? So all these medications are based off of what you need to do for their treatment. The other notorious thing is the fact that ACE inhibitors can often cause that dry cough, right, because of the bradykinin. So you switch them off of the lisinopril and put them on losartan and ARB. But you can't use ACE inhibitors and ARBs together. That's not a good idea. Poor outcomes are seen. Periodically test for end organ complications. So you check their eyes, you check their kidney function, right, with urinalysis and so on. BUN, all of these things. Right? This is all given here very nicely. So not the most intense topic. Not that crazy either. Not that crazy. Right? It's not really bad. But where it does get a little out of whack is the secondary stuff. So this all depends on how much you talk to your friends about things they're going through. A lot of my friends tend to talk to me about their medical conditions very frequently because they know I'm not only a YouTuber, but also because I'm going into medicine and I'm trying to become a doctor. So they enjoy having these conversations with me. And I've seen all of these case scenarios either in test or in reality. One that I've really only seen in reality is oral contraceptive use. A lot of people who are put onto oral contraceptives can actually end up having hypertension, and then they get headaches, which is really bad because most women, as I've said earlier, I think in the step 1 class today, that chronic migraines are more commonly a thing for females, not males. Right? We were doing in the step 1 course today, we were doing the topic of coarctation in the aorta, where men present with really bad migraines, really bad headaches because of the increased pressure of blood going into their brains, right? And then they get a aneurysm and they can die. So that's a case scenario for men. For women, it's more common though to have chronic migraines. And then if you give them oral contraceptives and the migraines get worse and stuff, it's just not fun. Right? It's just not worth it. There's no point of using an oral contraceptive in that point. You would have to switch to a different method of contraception. So you're going to see that topic when you get to reproductive here in gynecology and obstetrics. This topic was the main guide though, renal artery stenosis, big topic in step 1, right? Then I broke it down for you guys over here. So they tell you, especially common in patients that are young or very old with recent onset hypertension. Etiologies include fibromuscular dysplasia, which happens in young, usually female patients, and atherosclerosis in the older patients. So both are different ways of having renal artery stenosis. You diagnose it with an MRA or CT angiography or renal artery Doppler ultrasound. Ultrasounds are very easy to do, very effective, very quick. May be treated with angioplasty or stenting. Consider ACE inhibitors in unilateral disease, but in bilateral disease, ACE inhibitors can accelerate kidney failure by preferential vasodilation of the efferent arteriole. Open surgery is the second option if angioplasty is not effective. So I broke that down for you guys here. I wrote, in renal artery stenosis, patients release a lot of renin because their kidneys are not really working that well with the arteries being stenosed. Administering an ACE inhibitor will lead to more renin release due to the feedback of decreased ACE function. Right? So remember what ACE stands for? Angiotensin constricts the efferent. right? If you take an ACE inhibitor, you stop the efferent constriction. ACE stands for angiotensin constricts efferent. If you get rid of that, you end up having no more efferent constriction, right? So that's what they're talking about here by preferential vasodilation of the efferent arteriole. That's going to lead to more kidney failure because you're going to have things passing through the kidney quicker than things are actually coming into the kidney since there's renal artery stenosis. So you end up really amplifying how much renin they make in these patients who have already been making a lot of renin because they have arterial stenosis. Remember what renin did? It's the RAAS. So renin, of course, renin angiotensin, yes, but then also renin aldosterone. The excess renin will still amplify aldosterone activity, even though you're taking an ACE inhibitor and you won't amplify angiotensin activity, that's fine. You're still going to be amplifying aldosterone activity since the ACE inhibitor will only prevent angiotensin 2 production. A systolic diastolic brute lateralizing to one side has high specificity for renal artery stenosis, right? If they tell you they hear a brute on either flank or something, that's usually because that renal artery is the one that's causing the brute. Right? All that aldosterone would worsen their blood pressure levels, and then you know right away to stop the ACE inhibitor and start looking forward to doing one of these surgical procedures to help them. Primary renal disease, of course, that can cause hypertension. You just give them ACE inhibitors, and they should, start getting better. Pheochromocytoma, huge topic in endocrine, right? As well as Conn syndrome, Cushing syndrome. All three are going to be discussed in more depth in endocrine, but they're definitely things you should have a good understanding of, right? Do that. So there's something I call the shock method of studying, where you would stop here, look at this, then jump to pheochromocytoma, study all the pheo stuff, then come back here, right? So that shock method of studying is a very effective method of studying on your own. You see something, you don't just keep going. If you keep going, not only do you not complete this topic, but also just gets boring, right? It's a very monotonous way of studying. See, if you see pheochromocytoma here and you don't remember it perfectly, and you can't close your eyes and recall the page of pheochromocytoma and how it looked like in first aid step 1, go back to it, check it out, right? Also look at how pheochromocytoma looks like in endocrinology over here and see how you would deal with it. So it's a good shock method of just changing topics that frequently. That way you don't really feel dulled out and you feel like you're doing research and stuff. It's a good feeling. Same thing with Conn, same thing with Cushing, right? Really make sure you feel very confident with Cushing syndrome and doing the different tests of evaluating what type of Cushing a person has, whether it's a pituitary adenoma or it's because of adrenal failure or whatever it might be, right? Adrenal cancer. So you want to make sure that you know these things very, very well. We're going to get to it too, but it's much better at this point to study these on your own, really know it, and then when I get to it, it should just be a revision. Coarctation aorta I just mentioned, right? We were talking about it earlier in the hypertension cardiovascular topic in step 1 class. And then hyperparathyroidism, another thing that just, you're going to have too much calcium. So high calcium has many side effects, right? The stones, groans, moans, and all of that. So, of course, this can lead to hypertension as well. And then hypertensive crisis. Okay, so look, here on this table, the CK book did a pretty decent job giving you a refresher of all these renal medications. But what you want to make sure you do is you go back once again to first aid renal and look at it all in depth. Have a good understanding of each of these medications. Those are all things that you should have had a pretty good grasp of before your step 1. But it's always great to revise. You need to do the revision for yourself because it's less likely to get very technical questions about each medication. But it's still possible to get an answer choice where instead of telling you the name of the medication, they'll tell you the mechanism of how the medication works, and that's how you know to pick that, right? So it's still pretty silly in that respect. So for the hypertensive crisis stuff, anyone with over 180, 120, depending on whether it's urgency or emergency, you really just have to give them medications that immediately drops everything, right? Immediately fixes everything as fast as possible. So they tell you here, just, beta blockers, clonidine, and ACE inhibitors for the urgency stuff. For emergency, you need to try with IV medications. Okay, very important to catch that here. This is a CK topic. Treat the emergency stuff, people who are starting to get end organ damage or are about to get end organ damage. Give them IV labetalol, nitroprusside, nicardipine, any of these. Nicardipine being a really good medication. Also remember nimodipine, which was very important for the brain as well. Right, that was a different medication, so you want to make sure you know those calcium channel blockers very well. And the goal here is to reduce the arterial pressure by no more than 25% over the first 2 hours. Right, you don't want to lower blood pressure too quickly because if you do, you could end up getting cerebral hypoperfusion, or you could end up getting coronary insufficiency. You don't want to end up not sending the right amount of blood to either your brain or your heart. So you lower blood pressure by about 25% within the first 2 hours, and then lower from there slowly over time. High blood pressure means you're sending a lot of blood to different organs. Some of those organs mainly being the brain and the heart. If you lower the blood pressure really, really quickly, you stop sending blood to the brain and the heart. That's not good. And then they can die. Pericardial disease, there's a couple things about pericarditis and all that stuff. Looking at this image here, very, very common topic, right? Once again, so in both my step 1 class as well as the CK class, I've mentioned to be studying respiratory along with cardiovascular. So while we're doing cardiovascular here, you could jump to pulmonology CK. I wish I had already done pulmonology CK videos, then I could definitely add you guys to it, but I never even got that far. But you can always go back to respiratory first aid step 1 and check that stuff out, because these topics are all talked about together. So this is a very interesting image, right? This is the thing you always see in respiratory, except it's usually drawn a little differently. In respiratory, you see this being drawn like this, right? Like that. That's the breathing thing that you always see, and you know, if it moves to here or if it moves to here, you figure out that whether it's restrictive or obstructive kind of breathing problem. So in this patient, they tell you that look at what's happening. Every time he breathes in, right, the blood pressure seems to fall down, right? So the blood pressure falls down. So every time he breathes in, the blood pressure falls down. That is a huge topic of pulsus paradoxus, right? Pulsus paradoxus, and they tell you in this question, 34-year-old woman comes to the emergency department, difficulty breathing and dizziness, arterial line displaced, and her blood pressure tracing is shown like this. What is the most consistent diagnosis with these findings? And the correct answer for this one was severe asthma. Right? Severe asthma, but there could be many other things that can cause it. The tracing shows pulsus paradoxus. Cardiac tamponade is the one that's notorious for causing pulsus paradoxus, but there's a list of things that can cause it, not just cardiac tamponade. Severe asthma is one of those things. Okay, so pulsus paradoxus and the respiratory flow rate is consistent with normal for the most part. This is the normal respiratory flow rate. The flow rate was slightly useless here, but all it really wanted to show you was that when breathing in is happening, that's the point where this decrease in blood pressure is happening. That's all they put that there for. Just remember, pulsus paradoxus is related to ventricular interdependence and pericardial issues like tamponade, as well as asthma and COPD. All right, so all of these are case scenarios where you see ventricular interdependence. So what is ventricular interdependence about? Well, let me see, finding a good spot I can draw. All right, let me just do it right up here somewhere. Wow, I really didn't leave much space. Okay. Okay, let's do this right here. So, you have your heart, okay, and you have your interventricular septum, and then your interatrium. I say this is your left atrium, left ventricle, right ventricle, and right atrium. So when you breathe in, more blood comes into your right heart, which means more blood goes into your right ventricle. Now, if a person has cardiac tamponade, they have this bag of fluid around their ventricles, right, full of fluid, which basically is essentially compressing your heart, right? It's compressing your heart. So now when your right ventricle is filling up, generally speaking, you would expect the ventricular wall to expand so that it could fill up. But now it can't. So when your right ventricle is filling up, the only thing it can push is push the interventricular septum into the left ventricle. And that's what causes the drop in blood pressure. Drop in blood pressure. So every time they breathe in, their blood pressure goes down. That's because you have ventricular interdependence. The ventricles are depending on each other to make space for each other, because they can't expand outwards. There's decreased compliance due to this tamponade fluid outside. Right? That's what that ventricular interdependence topic is all about. So pericarditis, an inflammation of the actual pericardial sac, can actually compromise cardiac output due to tamponade. And the exact scenario which I just drew out for you guys would occur. Right? And there's many types of pericarditis that can occur. You can have viral myocarditis, constrictive pericarditis, and then yeah, I think that's the only ones we need tables for. And there's other ones that can occur too from, of course, the list they have here, all the different types. But generally speaking, oh, there you go. This thing causes a pericarditis. All the different things that can occur, right? But generally speaking, very important to make sure you can understand, or at least have suspicion for some of these scenarios. Because what often happens in questions is you might have a patient who had a simple cold like 2 weeks ago, it resolved by itself, and now the patient's presenting with weird symptoms, cardiovascular. So costic UB is a big culprit of that, right? Not only does costic UB possibly cause pericarditis, and the patient would have to have symptoms of restrictive kind of, viral myocarditis, but this stuff, costic UB can also cause dilated cardiomyopathy. It's the C of ABCCCDs, all the things that cause dilated cardiomyopathy, right? Physical exam, well, generally the main thing is going to be that you're not really going to be seeing anything crazy besides the pericardial friction rub. Like, you're not going to have any changes in, or at least not any major changes in sound, but the pericardial friction rub is the key thing. And UWorld, AMBOSS, they all get very creative with how they describe the pericardial friction rub. So if you read something and it sounds like they're talking about a rubbing sound or something, then that's what they're discussing. Right? So you want to make sure you grab that. These practice questions are wonderful practice questions I handpicked where people got everything wrong, right? So like, look, 25% here chose the wrong answer choice, which was constrictive pericarditis. So that's wonderful to see how you would not pick constrictive pericarditis. Here, only 25% people chose the correct answer, which was constrictive pericarditis. Both of these were wonderful UWorld questions that had a lot more to teach than just what you see in the question. But treatment, generally speaking, you just get rid of whatever's causing the pericarditis, right? Treat the underlying cause. Treat the idiopathic cases with NSAIDs, such as ibuprofen, naproxen, or indomethacin. So if you don't know why they have, if there's no clear cause of the pericarditis, then it's idiopathic, which means this is just happening for no reason whatsoever. STEP loves that stuff, right? STEP loves anything idiopathic that can happen because that leads for very, very confusing questions where apparently something's happening, but you can't find a root cause for why it's happening, right? And if things get worse, that leads to cardiac tamponade, which brings us back to our wonderful ECG. So I've put practice questions once again with the ECGs and stuff, right? You can see everything when you do the ECG questions. So like, for example, if we look at this one together, right? So same evaluation every single time, right? You do the breaking down in half, you look for V1 pointing down, AVR pointing down, perfect. And then you look at 2, 3, and AVF. There are some issues here already, right? So you can see it already. You could already see this happening, this loop happening. Very similar to the pulsus paradoxis thing. Right here, I'm noticing that these are very, very faint. Barely, the electrical signal is barely coming through. Right? So there's something wrong with this inferior surface. And then if I look at the heart rate, again, I can see that, sine wave kind of loop happening. Right? Very weird. These are not isoelectric. Right? And that's what I'm describing here. So there must be some kind of pericardial effusion, and you go ahead and manage this patient. Right? So the correct answer for this question, which was literally what is the next appropriate step in management, was just to do a transthoracic echo, And the book loves picking answer choices where, STEP loves putting answer choices where it might say transabdominal echo, and that's a trick answer choice because of course you're not looking for the heart in the abdominal area, right? But they put that there to catch you, and if this is the 200th question you're doing, you're gonna pick that because you might be that sleepy or something. Right, so that's generally what you look for. Here though, this one is very interesting. So this is showing you pericarditis, right? You're gonna see diffuse ST elevation. So of course, when you do the same evaluation as always, you see your things and you already start seeing problems, right? Something looks weird here. This looks weird. This also looks very weird, right? This is such a strange thing happening pretty much all around, everywhere. V1 was okay, but remember V1 doesn't have much anyway, and V1 and AVR are both pointing down, so okay. But up to V6, even here, there's a weird ST elevation everywhere. And then when you look at 2, 3 AVF, once again, you have your ST elevation. It's not coming back to baseline. Right? And here, and 3, I can barely see anything. It's got a very blank line for the most part. So when you see this kind of stuff happening, and then you combine that with the clinical presentation of the question, you should have not much trouble picking that this is some kind of pericarditis, right? So that's what you're looking for in these. And I put another ECG here showing electrical alternans. Once again, the same sine wave loop I was making. That's what you're looking for. So the electrical alternance, you see, this is the sine wave kind of loop happening. Okay, very, very weird. The sine wave that I'm referring to is a sine wave from math, like sine and cosine, that thing. So it's a very, very easy thing to catch, simply because there's such a distinctive thing for it, right? Like the ECG might have anything else to it, but if it doesn't have the sine wave thing I'm talking about at the bottom here, then you don't pick tamponade, you don't pick pericarditis, and you just pick something else. Right. Valvular heart disease we already discussed with the mitral stenosis and all those other things, and then you have your vascular diseases. Vascular diseases being the last thing to talk about before we can finally move on to endocrine. But I'm gonna save the vascular disease thing to do it as a live session for with all of you guys, because I actually want to look it over one more time and find something else that I want to mention with this. When I do the step one, I'm going to go through the step one book and find something that's relevant for all this as well, because first aid CK is very incomplete. It's much more complete in my annotated version, but generally speaking it's pretty incomplete. I also ended up finishing pretty much annotating everything. The last thing left to annotate is just renal, so I'm finishing that up now. So I'm going to send you guys the updated book as soon as I'm done annotating renal as well. And actually I'll send it out so you guys can use the book for respiratory as well. So I'm done annotating respiratory. I put a bunch of practice questions, a bunch of tables, more images, more x-rays. So it's very, very, very helpful stuff, right? I added blank pages to put more information in. So I'm going to send that download link out with this email. Keep working hard, and then I'll see you guys again very soon to continue on into vascular disease and wrap up cardiovascular.